Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Well, isn't it interesting
to
watch a live stream of the Auburn Medical Group with...
You made it.
Dr. Mark Vaughn and Dr. Gwen Vaughn. That's me. Okay, so thanks for joining us. We are speaking this week on... Do you know what we're talking about? Do you know the subject?
I think telemedicine.
Telemedicine. Kind of like what we're doing here, except...
Hey, it's two-way.
Except we're not practicing medicine.
We're not practicing medicine, but we're
if the state board ever asks, we're not practicing medicine.
The state board comes to
over
your house
YouTube.
Saying,
No,
will
that's
you
right.
testify against the doctor's
house.
Vaughn.
When they come to your house, when they come knocking. I think we've heard that phrase in certain environments before, maybe with certain close relatives we were just talking about. When they come on your door. Anyway, thank you for watching this show. We will be talking about telemedicine very shortly, and we thank our viewers, our longtime viewers. We thank our look at that. We already have people on the chats here. We'll go ahead and put that in there. That we have people greeting
staring
us.
at me here. Cover your eyes.
So Elvis Cree says hello, Doug. Hello, Elvis Cree. We're glad to have you be a part of the program. For those of you who haven't seen this before, there is a live component to this of people chatting in because we do this almost every Monday at 4:30. Maybe not next week.
That's right.
We'll see what happens. Sometimes we do when we're on the road. And the show is all about the live program. Watching it after the fact may not be as much fun. So make sure you're subscribed and hit your bell icons to get the notifications so you can be part of the chat. So, telemedicine, we started it. I don't know, did we start it before
COVID?
I think we had dabbled.
We had. It really came into existence with COVID because it needed to. Kind of out of necessity there. And a lot of the regulations necessarily or by necessity changed to make that an option.
Yeah. Yeah, it's kind of one of those things where
reimbursements and other things.
Innovation came of necessity.
Right.
So, let's see, we were doing it, 20% of our visits, I think, at the
peak.
High
point, yeah.
And what happened?
It's really dropped off now that we've kind of gone back to...
We used to think, well, how can you do that? Because you can't do a physical exam. Oh, it'll never work. We were very discouraged by the possibility of helping our practice before. Mm-hmm. And then what did we find? Some visits really lent themselves to it and actually worked really well. A lot.
It's pretty amazing. Now, there are things where you do need to do an exam and evaluate the patient in person, but a lot can be done. I have had the patient do physical exam for me.
Right.
Push there, do this certain maneuver, move your arms up here, across here.
I was talking about the phalens and the Tenels.
Yeah, that's right.
You can have it, and the dequervit, or the, what's it called, the Finkelsteins?
Yeah.
You can do certain physical exam things by educating the patient. You can see, because it's telemedicine, you can see that they're doing it correctly.
Right.
And they're going to elicit whatever sign it is you're looking for. So, a lot of it can be. And I just am amazed by how little of it we're actually doing. So we're going to get into, in a little bit here, what those things are.
What prevents us, what gets in the way.
Yeah, when it should be working, why isn't it? So,
right.
And it may not be what you think. So let's see what our comments and questions are over here with I don't know, maybe Tamara Lung saying...
Thanksgiving.
Hello, happy Thanksgiving.
Actually, my son wished me happy Thanksgiving this morning.
Oh. What's his connection with the Canadians?
Nothing, just the calendar that he looks at every morning.
Yahtzee. That's actually what they call it.
Yahtzee.
Okay, so telemedicine is not good. I'm reading here. That's not me saying it. I am a nurse and a patient. Much gets lost. Maybe telemedicine in certain medical. Okay, so let's explore that. What Yahtzee has against telemedicine.
It's not good.
It certainly isn't universal.
For sure.
And there
I definitely agree with that.
Lots,
you can't use it for everything.
Most things with acute symptoms, we'd probably prefer to have the patient in front of us and be able to touch.
Listen.
But again, touch, like we were just talking about the wrist type of, you can have a patient push around and find out where their anatomic snuff box is there and find out where the end of the radius is and go through and palpate for you to see if there's you can do, or to see if something's squishy, like if you're trying to determine if there's fluctuance.
Yep.
As well as, as far as if is it an abscess you can drain.
Right, yeah.
They can't be less accurate than doctors are on that without ultrasound.
Right.
So we're curious to see what Yahtzee, what specifics. Okay.
Could be okay.
Okay.
You're coming over to our side.
Yeah, you're with us there. Okay.
But yeah, there are certain things, like you're talking about acute things. If somebody has a cough, I really want to listen to their lungs.
But that stethoscope you have.
Yeah,
it is not too far off that I could imagine patients being able to allow us to hear their heart and lung sounds without coming in. Now, it would be like the people who, buy every gadget there is because they can and figure out how to hook it up so it's not at all mainstream.
Yes.
But I could imagine it being adequate that I could say, yeah, I can tell, I hear the lung sounds and I'm hearing normal sounds. I would be hearing rows if they were there. Right. I mean, I hear enough of this. You know how sometimes you listen to clothes and you don't hear anything?
Yeah.
Well, you're not sure you didn't hear something when you don't hear anything. But when you do hear good, full lung sounds, you know that if it's there, you would have heard it.
Right.
So you've got that kind of control, I guess I would say.
Yeah. They have all sorts of gadgets out there, like the little video thing that you can look in your ear or...
which we've seen on the show. Yeah.
So part of the thing is video, and the feed that's going through and how good we can see
okay, so now we're getting into why we're not using
it. Yeah. So maybe we should start there, because that does play into that, because theoretically you should be able to look at a video. Here you can see me pretty good, probably high definition, and look at my skin and maybe figure out what rash I have or whatever.
The same thing is at play. What are they watching us on?
Right.
Except it's
what's your connection?
Because we, of course, have a broadcast quality camera that is starting with the signal, but then it gets compressed to get into YouTube, and then it gets through the internet to somebody's, who knows how fast the connection is, and then what are they watching? Are they watching it on a phone screen that's this big?
Right. Yeah, lots of things at play. So, and you can think that is just magnified when we're doing it two ways, and then we've got to see what kind of camera the patient is using. Are they using the most modern, iPhone out there with its HD camera, or
a Chromebook,
or something that's got 8 megapixels.
And then the issue of the connection on their end. How much bandwidth is being used?
Yeah.
Is it going through their home Wi-Fi? Is it going straight up to a 5G connection? What's the network traffic like? Is that limiting how much information or
lots going,
how much compression can be used? So we have the service that we use. You can pay more for high definition, and we did for a while.
We did. We tried it out.
What was your experience when you were paying for the high?
So high definition is great if you have somebody with a connection that allows for high definition, but that was not the case. Especially, we're in a more rural area, so we have patients in very rural areas, like out in Forest Hill, up in Grass Valley, Nevada, Georgetown. There are the connection on their end is not always the best. They're not in the middle of the city with their cable connection or fiber or whatever.
Fiber.
So we're getting that signal. So we did not find any improvements, or it wasn't typically high definition, even though we were paying for that.
It was disappointing, and you want good visibility, depending on what it is you're doing. If it's more about sounds or in general how the patient looks and how they're talking.
Even then, if you're kind of every once in a while pausing, you're like. And you're waiting for it to catch up. Even that can be an issue sometimes.
Do they have a neurological problem? Are they talking that way? Or is it just their internet?
Just dropping out? Yeah. I'm sure you've done this too, where you've got the video here and then you've called them on the phone because it's a better connection over the phone to hear them. So you're seeing them, but you're talking to them over the phone.
I'm not seeing any movement here. Is this the Senate Majority Leader, or is this person having a bad connection?
Wow,
I don't know.
You went there.
So let's get some of our comments and questions here. What do we have? We have.
I don't know if there's anything new.
What? There's no
Come
new
on.
comments. Oh my goodness!
It's their connection.
Okay.
We paused and they're just not.
They see us in mid-sentence. Yeah, that's what's going on. I was counting on them. Okay, so the connection was a big part of it. The equipment they have is a big part of it.
Right. Ability.
Okay. That was the other one. Yeah.
Yeah.
A lot of our patients, first of all, if they somehow get access to the technology, the smartphone with a camera built into it, or a Chromebook for that matter, or a laptop, then there's our patient population, which is, we've talked about this before, by far elderly and Medicare.
Yeah.
And there are some of them who are, have I ever told the story about my patient who was over 100 years old? And let me tell you when this happened. This was over 20 years. Let's see, we've been open here 18 years. Okay, so about 20 years ago. This guy was 100 years old, and his biggest complaint was not being able to get fast enough internet to do his day trading.
At 100?
20 years ago.
Wow.
You know, what were you doing with the internet 20 years ago?
Wow.
And this guy was upset because he couldn't get fast enough connection at his home, his residential facility he lived in, to do his day trading. So you have those people. But there are a lot of the patients who are 65 and older who really don't, more so the older, who don't do well with technology.
And some just don't want to, which is fine.
That's the other thing. They don't want to learn.
Not how they grew up.
We have some patients. So to force telemedicine on that situation is, don't do it.
Right.
But there are situations where it is really, really hard for the patient to get into the office.
Yeah.
Real transportation or mobility issues.
Yes.
And you still have to treat them. And so that's when you fall into this, well, let's see what we can get. And
I actually just recently had a patient who came home from a back surgery, and she was essentially bedridden for a while. And that's how I had communicated with her. She unfortunately ended up back in the ER. But yeah, that's how we were communicating for a couple of weeks there while we were trying to take care of her outside of the hospital. So
and
in that case, it was helpful, very helpful.
More often than I like, we have this experience. So the insurance will only pay for telemedicine if it's actually video both ways,
simultaneous,
and audio. And sometimes we'll have just enough of a connection that you can look and see how they move, how they talk, how they breathe,
you're upright,
expression on their face. And then at that point, you go to talking on a phone. Sometimes I'll still be looking at them.
Yeah.
You know, they'll have another phone. To be able to get the audio part through a telephone, because they can do that, or just completely go to that because the bandwidth just is not enough for doing the video part of it. And it works, and we'll fall back on that and still get done what needs to get done. But I don't like when that happens.
Right. Yeah, it is kind of amazing how much of a exam you can do. You start to think about things that you don't think about in person, because if somebody's speaking a full sentence, they're not, short of breath. You can see that they're not huffing and puffing.
You can see accessory muscles of respiration.
You can see if they can move all extremities equally, or
the accessory muscles lifting up the expansion of the chest. You can see pursed lip breathing. When
so you can make a lot of
stuff there,
lot of assessments about just by visualization.
See them wince when they move, when they get up.
Yeah.
We've got some comments here. I believe doctors, I can't read it on. Doctors need to look, hear, and listen.
Ideally,
it is definitely helpful.
Agreed.
But you do want that do you want that responsibility, doctors? Patient does not have the most modern equipment, not necessarily. That's what we're talking about. Absolutely. But when people do have, and this is the thing. We were just, what you're saying there was exactly what was coming out of our mouths 3 years ago. Exactly.
Yep.
And then when we started using it, we realized, wow, a lot of what we do lends itself to this.
Right.
And can be more convenient for the patients, less wear and tear on the facility and use of ancillary help in the office.
Right.
So it can be a reduction of cost of healthcare.
Absolutely.
By doing more telemedicine when it's appropriate.
Yeah.
And it is, I don't know, do you think, we were doing about 20%. Would you feel like maybe half of our visits, you'd be able to practice medicine as well? I think it's probably around there.
It may be.
I mean, I think it's a lot more than 20%.
You can do all your Medicare annual wellness exams that way. I mean, I've done those. You can, all those check-ins, all
diabetes
mental
visits
health,
where you're going over
reviewing labs.
Once a year you should see them to actually.
If they have a good home blood pressure cuff, you can do a blood pressure check-in.
Or just have them on RPM.
Yeah. If you have the appropriate equipment and.
Yeah. So I don't think I'm ever, at least not now, promoting telemedicine only. I think I want to see the patient, touch the patient, probably on an annual basis for most chronic illnesses.
I agree. Absolutely.
Yeah.
I think telemedicine is not here to completely replace what we're doing, obviously. It is a good ancillary service, a service in addition to what we already do. We cannot do what we do completely in isolation from a patient.
I was thinking about that today, I was reading about some stuff going on where in more rural areas, they're using a lot more telemedicine. I thought, okay, could we just take on patients anywhere in the state?
Yeah.
And then I thought back and realized, no, I want to have that in-person visit with anybody who's a patient in our office.
Right.
Probably as the first visit.
Sure.
And then we can talk about whether things are appropriate for telemedicine or not. And I could imagine having somebody be a patient, like somewhere outside of Reading, for example.
Yep.
And make it work. If they can get down here once a year, if something acute was going on, we'd probably be relying pretty heavily on some urgent care. Yeah. Okay. So the comments.
Yeah.
We jump back here to Hilda. Hilda saying, I think it's great. Saved me when I couldn't drive, but still needed visits with my cardiologist.
Look, even a cardiologist, and actually I've seen that cardiologist utilize that fairly often.
And then I happened to be in Auburn a few months. Oh, cool. Hey. You should have stopped by and say hi.
That's where we're at. Well, Auburn, California. Hopefully you were in the right Auburn.
Yeah. And then Hilda also says, negative side, it will be an unfortunate substitute for hands-on care for the fast. Oh, there's people doing that. Don't worry. There are people doing that.
Yeah.
We're not them.
You're right. That is something that you're going to see that. So for some things that could probably work out, like psychiatry, I can see that working out, for those mental health type visits. But for what we do, I can't see it working out. I have a colleague of mine who I was a little ahead of him in residency. He's a family doctor, and he is up in Idaho doing fully telemedicine medicine. I don't know how he does it. He started his own company and everything, and I really don't understand it. I've just seen some of his updates on social media, but I don't know how he does that and
never
operates.
Sees them.
That's how I understand it. So I don't know how that works, but
it's better than people not having any care.
Right. And that's the other thing. Is this something we can?
But we can. I mean,
export to.
How often is a situation so bad that it's either telemedicine or nothing? If that's the case, telemedicine is better than nothing.
Going to be better. Yeah. If you live in,
but let's not just fall back on it.
Wyoming and you're hours from the closest care. Yeah, telemedicine is probably going to be very helpful for you.
Maybe in those states with really rural populations and less care, we should get licensed.
Oh, there you go. We can just do it.
It's an idea. We'll give you an update on that. Okay. We also have Yahtzee as a retired nurse married to an internist cardiologist. We already did results by phone. We in the office would miss so much for a. Are you still typing? Okay. Not sure where that was.
Yeah, I mean, I've done those quick follow-up visits. They tend to lend themselves
great for follow-up.
You see somebody, you're order some labs and just are doing a follow-up on some labs to review some stuff, and you've already done the exam and that hasn't changed, it can be helpful in that situation.
Again, earlier I said acute signs and symptoms. I'd like to have that in-person evaluation. When something changes,
probably need evaluation.
Let's talk about it over telemedicine.
Yeah, and we have done that where we're doing a visit over telemedicine, and
see
we're like,
if you can tell enough that you won't have to. But when it's like, a change in respiratory status, I need to be able to examine.
Yeah.
And not just listen. I mean, to be able to percuss.
Right. Yeah, it's more than just
feel for fremitus.
Yeah.
Those are things that I'm not going to be really quick to. Things that require more of
there are
skill.
To note, when you are sitting across from someone in person, there are things you can pick up on that you will not pick up on a telemedicine visit.
The smell of the ketones on their breath.
Absolutely. Yeah, that the small tremor they're having in their right hand when they're,
or the smell of the bacterial infection.
Yeah.
That they don't know they have between their toes.
Right. Yeah. Watching them have an ataxic gait as they stumble out of your office. Things like that.
Well, you can have them walk.
You can. I'm just saying, these things, are
they can have the camera where they can. Yeah.
Right.
Okay. All right. So with that, I
do say telemedicine visits lend less to, or I have less, by the way, complaint things with telemedicine visits. Have you noticed that?
I think you're right.
Yeah, maybe it's because we're not in person, but I feel like I can take care of what the thing is and then say, all right,
I never really made the connection, but I think you're right.
Yeah.
Which makes me love it.
Yeah, because those are things that make our job a little harder.
Yeah, we went over that in an earlier show.
We talked about that before.
An earlier rant
that's something
that was televised.
I just thought of.
So thank you so much for watching. We do always mention Lindsay Antoine's name. If you want to know how you can get yours in, look at, Patreon, I guess. Until next time.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.